The human body operates as a single, highly interconnected network. The immune system continuously communicates with the nervous system, hormones drive metabolic function, and the gut regulates both immunity and brain chemistry. No organ functions in isolation. Yet for the last century, modern medical infrastructure has been built in the exact opposite direction. We have divided a completely integrated biological system into isolated, disease-specific silos. This diagram outlines that disconnect. Healthcare delivery is largely organized around specific organs and conditions. A cardiologist isolates the heart, a neurologist the brain, an endocrinologist the hormonal pathways. The problem arises when treating chronic, multi-system diseases. Obesity and diabetes do not respect strict boundaries between medical specialties. Treating them in isolated silos frequently results in overlapping tests, duplicated treatments, and heavy medication burdens with side effects. Suppressing a symptom in one system without communicating with the others often means the biological root cause is entirely missed. An organ-siloed care model is structurally mismatched to the reality of human biology. This mismatch has created a persistent gap in our ability to reverse chronic illness. Recognizing this gap, patients are increasingly seeking out complementary and alternative medicine, or CAM, to address their health holistically. This creates a phenomenon known as parallel play. A patient maintains their conventional prescription regimen on one track, while independently adding botanical supplements or alternative therapies on another. Neither provider knows what the other is doing. This lack of structural integration creates severe risks for iatrogenic harm. Without clinical oversight, an active botanical agent can dangerously alter the metabolism of a prescribed pharmaceutical, leading to toxic, unmonitored drug-herb interactions. A functioning integrated system is built on rigorous structural cross-training between disciplines. Permitting access to alternative therapies without clinical integration directly introduces systemic risk to the patient. Building a safe, integrated system starts with establishing hard clinical boundaries for complementary practitioners. Complementary providers cannot operate in an epistemological vacuum. To participate safely in patient care, they must receive foundational training in evidence-based conventional medical science. The most critical safeguarding skill in this process is red flag recognition. If a patient presents for a yoga therapy or acupuncture session, exhibiting sudden unexplained weight loss or an acute onset of neurological deficits, the practitioner must recognize these as symptoms of potentially severe underlying pathology. At that exact moment, the clinical protocol dictates an immediate hard stop. The practitioner must escalate the case and refer the patient directly to a conventional medical doctor for diagnostic imaging and testing. Equipping alternative providers with conventional safeguarding protocols serves as the primary defense against missed critical diagnoses. The responsibility for integration goes both ways. Conventional physicians must broaden their understanding to include the biological mechanisms of holistic and botanical models. If a patient is utilizing an Ayurvedic supplement, the prescribing MD needs to understand the specific evidence base behind that intervention to manage the patient's care safely. This chart categorizes chronic diseases and relevant Ayurvedic interventions. Look at the row for rheumatoid arthritis, listing curcumin as an adjunct therapy. The clinical guidance is explicit, the evidence is of low certainty, and it must not replace disease-modifying anti-rheumatic treatments. Conversely, examine the protocol for type 2 diabetes, involving the herbs fenugreek and curcumin. These herbs act through precise physiological mechanisms. They reduce carbohydrate absorption and support insulin signaling. They are active biological agents. When a conventional doctor understands these mechanisms, they can anticipate changes in a patient's blood glucose and safely adjust pharmaceutical insulin doses to prevent hypoglycemia. Conventional doctors must learn the physiological pathways of CAM therapies to safely manage patients utilizing multiple modalities. To eliminate parallel play, siloed providers must develop a shared clinical vocabulary. This graphic outlines the RG9 model, a structural roadmap for integrating diverse healthcare disciplines into a single coordinated system. The model relies heavily on two load-bearing pillars, promoting communication and education and training. In practice, this means linking conventional neurology terminology directly with traditional complementary practices so that all providers understand exactly what is happening in the body. This table maps specific breathwork techniques to their physiological outcomes. For example, the alternative practice of Nadi Shodhana is mapped directly to its mechanism of action, enhancing vagal tone and balancing hemispheric activity. Translating a term like breathwork into the measurable metric of vagal tone enhancement provides a cardiologist and a yoga therapist with the data required to co-manage a hypertensive patient safely. A shared clinical language replaces isolated guessing with coordinated patient care. We return to the primary failure of our current system: fragmented patient pathways created by rigid medical silos. A scientifically grounded model dismantles these silos, reorienting the care structure to match the biology of the patient. This diagram displays the integrated medicine model. Instead of isolating organs, therapies are deployed as a network, supporting the entire physiological system. By addressing interconnected root causes rather than isolated symptoms, this resolves biological mismatches. The result is coordinated care with a lower medication burden. Structural integration serves as the necessary evolution to successfully manage and treat systemic chronic diseases. For medical administrators evaluating structural reforms, the viability of whole-person care comes down to systemic efficiency. Shifting a healthcare system's focus away from repeated acute hospital interventions toward community-based prevention yields massive economic returns. This table tracks estimated reductions in healthcare utilization with holistic interventions. Data shows drops in GP consultations up to 25% and hospital admissions up to 18%. At a population scale, this translates to a 4-to-1 return on investment, saving £9.7 million. These outcomes are entirely dependent on rigorous interprofessional education. Mutual respect and required cross-training between conventional doctors and complementary practitioners close the gaps that currently put patients at risk. Cross-disciplinary training provides the essential load-bearing infrastructure required to execute safe, integrated medicine at a massive population